Uh, well, we want to welcome everybody to our first, I guess we're calling this a podcast, Ryan. Is that what we're going to call this thing?
Yeah, it could be called. Yeah, it's a podcast. I mean, you could call it whatever you want.
Yeah, whatever. It's a podcast to us. How about that?
Yeah, yeah,
I
exactly.
thought of a title. We could call it "A View from the Trenches," like we're in the trench looking over at the battlefield, and you're trying not to get your head blown off by the things that are going on in our industry right now. But I did want to make sure we introduce Ryan properly. Ryan runs the FMO here in Denver area where I live and where Ryan lives. Obviously, you have a nationwide presence, and I'd like you to talk about, kind of what you guys are doing different from everybody else out there. But then how are you helping us here in the Denver market too? So Ryan Murchie, take it away.
Well, thank you, Eric Cox. I appreciate it. And Eric's been a longtime partner of mine. I launched RMA in 2019, so we're only 7 years old, but we are rapidly growing, and that's just and that's more or less a testament to the culture that we've been able to build and resonate. I mean, all my staff here has that can-do attitude. We see problems and we focus on solutions. And really, when it comes to broker support, I understand it. I've been in distribution my entire career. And I mean, professionally, I've sold motorcycles and Sea-Doo watercraft, and I've been in Medicare distribution. So I've helped build independent Medicare insurance agencies for close to 20 years now, large scale agencies. So I knew when I launched in 2019 my own FMO brokerage, I understand what it takes for an agent, what an agent needs in the marketplace in order to actually grow. I understand that marketing is hard for a lot of people and that a lot of people need a little hand holding, especially in the beginning with advertising and actual lead generation, because it's great to launch a business, right? And it's like, hey, I have my own insurance agency. But when you launch your own business and you have your own insurance agency, it's really important to have quality lead flow into your agency. And how do you get that? And how do you stay up to date on all the different CMS trends and updates? And, so my value proposition that I've built here within RMA to help independent insurance agencies, it's pretty tough to beat. Because we have the technology, we have the support, we have the on-demand broker support, we have the printing at no cost. I mean, if you can think of it as an insurance agency, like, hey, I could probably use some help with this. I can almost guarantee you that we have the support and service to help with that, whether that be advertising, whether that be compliance, whether that be just general product knowledge. We're going to have your back there. So the infrastructure's here, and I think really the biggest testament is the employees that we have here on staff. They're absolutely excellent. I mean, absolutely fantastic between Brittany, Brenna, Luis, Michelle. I mean, these are some really smart, high anxiety individuals that are driving to make sure you're taken well care of. So it's been a really fun ride to be a part of.
Nice. Well, and I can even as one of your, and I'm by no means one of your top producers. I have a very specific way that I grow my business, but I'm probably one of the abusers of the free printing. I at least make the top 10 because it's a pivotal way that we grow our agency, and I know some of the others do the same. So we thank you for your great staff. Thank you for the resources you give us. So thanks for
Well,
what you
yeah, I
do.
think that printer now is doing about 3,000 pieces on a daily basis. So it's
We
not
have,
just you.
yeah,
Everybody's
we've
starting to
crashed
get
that thing
wise to
before.
it. It's $600 a month for that lease, so I sure hope you guys use it.
Well, let's do this. Let's get right into the questions. What we were going to do, I had put a few things out into the RMA group, a poll. I put out kind of a general question for what we could talk about. And then the final rule hit, and you and I were having a phone conversation, and it's like, well, let's let's forestall. So to the RMA folks that are watching this after we record it, we will get to the things that you put into the poll or into the chat on the RMA Facebook group. But what we wanted to focus on was the industry changes because it's going to be such a pivotal year. What I'm going to do is I'm going to be the role of questions, and then I'm going to tee those up to Ryan because what we really want to hear is, Ryan, what are your thoughts on the changes? And that's a lot of the private conversation I have at the in-person events that that you put on, those are the conversations that we're having at lunch, and those are the conversations we're having in the hallways between sessions, is these things that are coming up. So just want to appropriately put that out there. That's where we're headed. We'll get to the other stuff in a different podcast. A view from the trenches, right?
Yeah. Ryan's answers to Eric's questions.
Hey, there you go. We sound so official. So one of the people in our industry that I actually follow closely is the CEO of National Care Dental, Sam Melmed.
Yeah.
Sam Melmed. I think he's just a brilliant guy. He always stays kind of in the middle of the road. And Sam, on 1 week ago, was all it said on LinkedIn. He was talking about the final number. And so he said 2.48 is the final number, exclamation mark. My guess of 2.65 was off a bit. Can't complain. But here was the interesting thing I thought he said. Still low enough that there will be persistent commission pressure and not high enough to maintain current levels of supplemental benefits, but overall seems manageable for the market. Absolutely. So if you want to start maybe there, comment on what Sam said, but then let's pivot into your view as an industry leader. Similar to Sam, you have an opinion. Lead us into those, if you would, Ryan.
Well, so the biggest thing here is that we have to remember is medical inflation is not at GDP growth. We saw the CMS rate increase, of the 2.4%. That's following GDP growth. Medical inflation is at 5% right now. And so the rate increase at the Medicare Advantage carriers is still not enough, obviously, just to supplement that. But it was enough in order for us to see some stability. I really do expect, obviously commissions is a huge issue right now, right? The agents are all worried that all these plans aren't going to pay that I don't see that coming in the near future. I mean, the independent broker channel, the EDC agent channel, whatever you want to call us, accounts for over 55% of all new Medicare Advantage business into these insurance carriers. When an insurance company pulls a non-commission lever, they're not saying, hey, we don't want to pay commissions on this policy to insurance agents. That's not what they're saying. They're saying, we don't want new business into this plan. That's when they pull that commission lever, they're saying, hey, please, everyone stop enrolling individuals into this plan. It's not, they're not just attacking us. They're trying to slow the enrollment into the plan because it's non-profitable for them, and companies can't take profit losses for an extended period of time. That's just not how business works. So I do expect, obviously the commission issue to start leveling out. One of the biggest things was the risk adjustment model that these insurance companies and what we saw come down the pike with the Inflation Reduction Act, where the risk adjustment models are getting pulled back. And so we're going to see next year, more or less. I think I met with a few insurance carriers now that are really confident in the stability long term of the Medicare Advantage market, but understand that next year, with that risk adjustment model being peeled back, they're going to lose about 7% with that. But next year is the last year that we're going to see negative implications in regards to that. So this next year should be probably the last year where we see the most instability within the market. Obviously, because that risk adjustment got pulled back, so the insurance carriers are seeing a 7% reduction just there. And then obviously the rate increase they got from CMS doesn't keep up with medical inflation. Now, what I do expect as well is that this federal administration is gung-ho on getting obviously our medical cost and medical inflation down. And we can really see that with everything they're doing across the industry, and not just in Medicare. So they're incentivizing providers, and they're doing all these things to try to get, because we need the providers too, more or less. We have to have doctors' help here. And so really across the board within all industries, we see this federal administration really attacking that medical inflation number. So I mean, next year, yes. Next year, we're going to see some ancillary benefits obviously get pulled back. Yes, we need to be writing more standalone dental plans because we can't rely on our Medicare Advantage products to be the dental. They should have never been the dental plan in the first place. And I've been trying to tell. I'm very vocal with these things. And
yes, you are.
If you're in my distribution, you very much know, like, hey, this is not a dental plan. it's got some dental benefits in it, but it's not a dental plan. This is your healthcare coverage. You should be selling max out of pocket and what the risk is to the consumer over ancillary benefits. But we should see, we're going to see another year pull back on ancillary benefits because the rate increase did not keep up with medical inflation. We probably will see another year of some plans being suppressed. I don't like calling them non-commissionable because they are non-commissionable, but these insurance companies made it that way, not to hurt the agent, but to say, stop writing this H code. Okay. We can't take new business into this H code. It's losing money. Now I do expect the vast majority of non-commissionable plans that went non-commissionable this year to be service area reduced next. So we won't even have to deal with those non-commissionable plans anymore because the vast majority of them will be gone. And so I really do expect we're going to have one more year of turbulence, and then this thing is really going to level out. And that's my I don't know if I answered the question. I think I saw about 4 squirrels there, but if you got any follow-up questions specifically on that one, let me know.
They were good squirrels. We enjoy your squirreling. What I've noticed that in reference to the thing you're saying is, so we could call it peak 65 time frame, right? So between 26 and 27, we're estimated to start going on the down slope to my generation, which is Gen X. So as we get out of the boomers and as they taper off, it's going to keep going down like this for quite a while. But the total number of people 65 and above is actually going up.
Skyrocket.
So I see SARs, service area reductions, as an opportunity. But if the people are just going to be focusing, the agents in our communities are going to be just focusing on the turning 65s, or what we call T65s, I think we're missing the greater opportunity of those call center people that called the Joe Namath ad and got flipped into a plan that may or may not have been the plan that fit their needs the most. They're going to be looking for that local broker to say, hey, let's look at these smaller companies and perhaps look at how that might impact, so that total number of people. Comment, if you would, on the T65 versus maybe taking a step back and looking at that market and how we reach those people.
Oh yeah, absolutely. So obviously, the turning 65 market with our baby boomers, I mean, it's been awesome. I mean, it's been awesome to ride the wave of this baby boomers generation aging into the Medicare marketplace. And now, yes, the baby boomers, our T65 is going to start declining because obviously Gen X didn't have as many babies as the baby boomers did. And so, but again, like Eric said, the number of Medicare eligibles, or those on the Medicare program, is never going to be higher throughout this whole scenario. And so the folks that are just strictly focused on T65 advertising and not doing anything else, they very well may suffer when we start seeing the dip in the T65 industry. But what we coach, I mean, is not just to target those T65s, but to target the entire Medicare population. And one of the really big things that I see agents doing to really target that population is talking about Medicare supplement rate increases. I don't know if you've seen this, but Medicare supplement rate increases, I mean, I think the smallest one for a major carrier just this year was just under 20%. So these MedSup rate increases, I also see as a huge opportunity as well to advertise to those folks and say, hey, your MedSup premiums just went through the roof. Let's shop this. Because remember, with MedSup, you can change MedSups at any time during the year. They just need to be healthy enough to qualify medically to make that change. So if you're not advertising to those folks that are obviously taking huge MedSup premium increases, you absolutely should start. And there's a lot of different cool, funny, unique ways that you can do that, whether that be through a market, through direct mail pieces or through funny YouTube. I mean, we have one of our agents that'll put puts an old lady wig on and makes some funny YouTube videos about this type of stuff. I really, if you're going to do something, be unique, you know what I mean? And then also, these service area reductions that are going to be coming down the pike, especially in rural markets. Okay. Rural markets are always the most impacted when it comes to loss of revenue, because obviously healthcare costs in rural markets are higher. There's less providers. There's less things that they can negotiate. A lot harder to manage risk in those markets because a lot of the times folks have to travel to the more urban markets and use out-of-network providers that the insurance company has to pay because they don't have providers in their area. So so it's really unpredictable. So yeah, you definitely want to be target advertising Medicare supplement individuals because their premiums are going through the roof, and you could probably save them a ton of money. And then going into this annual enrollment period, we'll probably see another. We saw we saw an insurance company do a huge SAR on their PPO book of business. Okay. We expect that again next year. Obviously, we have some other carriers that made a ton of their products non-commissionable. So we expect to see another huge round of service area reductions. So how do you get in front of those folks? Well, obviously you can do that through traditional advertising methods. You can do that through, your YouTube advertising, whatever it may be. But also it's going to be through your community-based relationships. So if you're not in the field, creating relationships with community influencers, that is really going to be, your biggest way to generate new business, especially with the SARS coming up, is those community influencers could refer you 20 to 30 members a pop. You know what I mean? So it's building those community relationships with the influencers and real targeted advertising for the MedSup rate increases, as well as, hey, this next year, those annual notice of changes, there's going to be more changes in those ANOCs than probably ever before. So it's going to be really important that we're out there advertising to our community saying, hey, make sure to read your annual notice of change this year. If you are make sure to read it. There's some major changes coming down the pike. Work with a local trusted advisor that can guide you through this, and I'm here to help.
Good point. I especially in the SAR that we just went through, my hometown is Montrose, Colorado, and Montrose County is 2 counties south of Grand Junction. Montrose, the hospital system there has said, we're not going to take Medicare Advantage, period, anymore. Not at the company level, and I have clients in Eagle County, which is where Vail is, that have told me the same thing, that the hospital system, the name escapes me at the moment, but Valley View Medical, I believe, is the name. They've come out and said, we're not taking these Medicare Advantage plans anymore. That's not, I think, going to happen across the board. And I think the folks at these Advantage plans are working hard to get that reversed. But at the moment when that happens, then it's like, do you want cake or death? Cake, please. So It's like, do you want, when you're getting SAR'd, it's like, do you want to pay a couple $100s per person, or do you want no coverage? And that's that cake or death thing. It's like, the old Eddie Izzard reference, my favorite comedian, right, is, do you want this, or do you want the horrible thing? Well, of course you want this, but then you have to pay for it. How could agents in those situations help advise creatively in those situations?
So there are going to be some rural markets that aren't going to have Medicare Advantage plan. I mean, Montrose. We'll just use Montrose as a prime example here, because their main hospital, the Montrose Community Hospital. I mean, it's the main hospital in that county. That's where everybody goes. Doesn't accept Medicare Advantage anymore. Now they are still billing some PPOs as out of network. Because obviously they're going to get higher reimbursement rates that way. But we expect SARs specifically in those markets, because it's impossible for a Medicare Advantage company to manage costs when all their claims are billed as out of network. So do I expect very many MA players to play ball in those markets? No. So most of those folks, they are, in those counties, they probably will be SAR'd off of their Medicare Advantage product. And like you said, it's either, you go with just original Medicare Part A and Part B and don't cap, what your catastrophic could be, or you enroll into this Medicare supplement product and pay this premium. Now, there's some folks that aren't going to be able to actually afford a traditional Medicare supplement premium. We look, if someone's 73 years old is getting SAR'd, the most competitive premium in their area is probably around, $180 to $200 a month. And it's probably a brand new insurance company with a new block of business that, that's going to be, we don't know if it's going to be stable or not. So is it a good option to just take these folks and put them in the cheapest plan available in their market? Probably not. But obviously we need to quote. we need to quote these things for them. But something else to look at in those type of situations would be your high deductible type of plans. Okay, so if you have someone being SAR'd out of a zero premium Medicare Advantage product in a rural market where there aren't other zero premium options going to be available for the next year, well, let's use some I can't think of the word, but some critical thinking. Critical thinking. Okay, well, how can we reduce the cost of this Medicare supplement product because it's the only thing available for them? Well, we can look at programs like K&L. Okay, and we can look at the high deductible Medicare supplement options. And the K&L, they have maximum out of pockets on them, but they have cost sharing on all services. Premiums are way lower. Not very many med supp companies offer them. But if there are K&Ls, that may be something. You have a book of business in a rural market that is probably going to need a med supp. Start taking a look at the K&Ls available in your market, because they do, again, have the maximum out of pocket on them, but they also have cost shares on all services up to that max out of pocket. So it works very similar to a Medicare Advantage plan, but the premiums are significantly lower, and we're capping the client's financial risk. That's when I talk med supp, that's, everyone, hey, plan N, plan N, plan M, plan N, it's G, high deductible G, and K&L. Because those are the ones that are actually going to cap your financial risks. You know what I mean? Where there's a true cap, because it's covering those Part B excess charges. And that will, I'm never going to change my stance on that, because I do not want my clients to not have coverage for Part B excess, because as these doctors, they're dropping out of these Medicare Advantage plan networks because they're not getting enough money from these insurance companies, and they can bill the federal government more and get more from them. Now, when the feds start really tightening down on this, which we expect them to, this administration is absolutely gung-ho on cutting down on things, okay? And I mean, it's never been more clear. As the administration continues to cut down on things, we can more or less, can't you expect these doctors that dropped out of these Medicare Advantage networks to also stop accepting Medicare's assignment so they can bill 15% above Medicare's approved charges? Right. And so I think Part B excess, especially within the instability and the drawback on trying to cut costs within this industry, I think making sure to have that Part B excess coverage on our clients' Medicare supplement policies has never been more important. But take a look at Plan K, take a look at Plan L, take a look at the high deductible plans, because high deductible plan premiums, you're looking at, a lot of them could be $30, $40, $50 a month. And we're talking over $100 in monthly savings on the Medicare supplement premium. But, it works like a Plan G. As soon as you hit that, I think, what is the deductible this year, Eric?
$2,950.
It's $2,950. So it's a $3,000 max out of pocket for $30, $40 a month, maybe $50, depending on their age and depending on their zip code. But that's going to be a really good option for our folks that can't afford a traditional Plan G in these rural markets that may see service area reductions.
I actually presented that solution you just mentioned to somebody during AEP, and she was, it was interesting. Her background is she was a chief financial officer at a nonprofit, and it's a large one. And when I showed her high deductible G and some creative ways that I came up with to cover that, $2,950, at the time I didn't know she was, as high up in the company as she was, because I present it to everybody. I don't care how much money they make. And she kind of looked at it thoughtfully. We were on a Teams meeting like this, and she kind of looked at it. She goes, I think what you just presented me is the future of healthcare, which is that high deductible G. Where I live, a high deductible is like $15,000 for a couple. High deductible G is $2,950 this year, $3,000. And then using some of the other tools that we have, having a separate conversation about, could you use an accumulation annuity with that 10% typical withdrawal that they have per year? Well, if you put in that much money and your 10% covers your deductible, you've created this situation where you don't have that worry. I mean, not everybody has the money where they can put that into an annuity, but can you cover the $2,950? Like what's the range of out-of-network PPO max out-of-pockets on an MAPD?
Oh, they're all the way up to almost 11,000 now for out-of-network.
Yeah, it's a massive range. Whereas the deductible on high deductible G, it's $3,000. So
yeah, and I mean too, you're going to see lower. Remember, med supp commissions are based off of the premium. Okay, so you are going to see lower compensation because you're writing lower premium plans. But remember, too, it's still in the best interest of the consumer. And then
Yeah.
on top of that, as well, I mean, the biggest risk to them hitting their deductible right away is that Part A inpatient hospitalization deductible. Okay, and you can hit that Part A deductible every 60 days. So if they get hospitalized twice within, a 6 month
Benefit period. Yeah, that
they're
benefit period thing.
yeah, the benefit period thing. So the Part A deductible resets every 60 days. So if you have 2 hospitalizations within the course of a year, there's that $3,000 deductible just within those 2 hospitalization stays.
Done.
And for $20 a month on top of your high deductible G, you can cover your inpatient hospitalization deductible through A. So for $50 a month, you can have the high deductible G, and you can cover the biggest pain point that could cause hitting that max out of pocket quickly.
Well, and that's where I think it's important for people listening to this to ping your team. If we're talking about things that aren't familiar or these creative kind of solutions, Ryan has a whole team of people that know how to do this stuff. So call the broker line, email the broker, email address, and ask these questions. Like Ryan mentioned this on the podcast. How can I do that? How can I put myself in front of that?
You know what has quickly become our top form of communication is the broker support text hotline. I mean, it is incredible the amount of text messages we're getting on a daily basis from our broker channel now. And it's really cool because as that text message comes into our agency, it's distributed out to everyone in the company. The whole company sees it as it comes in, and the first person that's able to jump on it and respond does. So yeah, I mean, the info at RMA agents is the generic email line, but use that texting, use that text, use our 800 number, use us. We're here to help. We don't just talk on concepts. We actually coach the concepts in the back end as well.
Well, and you hit on one of the things I was going to ask you about, so let's just dive into it now. I know that you guys recently migrated CRM solutions. Yeah. I've tried a bunch of different CRMs from an agent perspective, and I've really had a hard time. I finally found one that I think is the one that I'm going to use going forward. But talk about the importance of, even for those brokers who are brand new, or maybe they have less than 20 policies or something, talk about CRM for those folks. Like, what can we do to help them build that foundation now to where you're not, in front of, like I've got 700, 800 policies and still running it on a spreadsheet. We don't
no,
want
you're
that.
not.
Well, no, I'm not now, but I have a good CRM now. We'll put it in the call notes. The podcast notes is the one I'm using. But for an agent that's brand new, talk about the importance of that CRM when you're small.
Gosh, it's so important. I mean, do you actually want to own a company, or do you just want to, Band-Aid together, a couple $1,000s in monthly residual income? There's the biggest difference right there. It's like, hey, are you just going to do this part-time for fun and just write your mom, your dad, and your family members as they age into Medicare? Or are you actually trying to run a company? One of the biggest things about running a company is proper data management. It doesn't matter what stage of the company you're in, you have to manage your data. The CRM is not just to manage your current client data. Obviously, that's extremely important, but it's also to make sure that you're following up on the prospects and the leads that you've generated in the market as well. I can't tell you how many damn times I've spoke with an agent that has went to a community event and collected 30 permission to contact cards and then never did anything with it.
And then sits on them.
And then, yeah, they just sit them out on their desk, and they're just sitting there, and they might call them once or twice. But if they were to take that data, the prospective client data, and put it in a CRM tool that drips a newsletter, or drips, a happy birthday, or sends out an automated happy birthday message, or literally does anything whatsoever, you're going to get better lead conversion, but also client retention is extremely important, especially when we're in an unstable market. And the Medicare Advantage and Medicare supplement markets right now are unstable. So communication to your current book of business has never been more important either. So you're staying in front of these folks, because advertising, you think because, we may see some commission some commission cuts, and some carriers have done some dumb things and pulled, have oh gosh, what are they calling it? They've cut back commissions and they pulled that lever and said, hey, stop. Do you think that's going to stop the advertising from national agencies? No, they're going to now have new pain points to reach out to your members with. So if you aren't reaching out to your members with the pain points coming through and talking to these folks, then you don't have a real business. So please own a real company. You all do. And here's one of the big things too that I see in the industry, right? Is, hey, I'm going to partner with this FMO because, they're going to offer me a free CRM, or they're going to offer me a CRM. Now, as a business owner, right, the only thing that I truly have control over is my own data. Now, could I roll out a CRM for all of you and say, hey, yeah, just use my license, put all your client data in it, and yeah, you'll be just fine? Yeah, sure, I could. Absolutely could, but I don't want to. Guys, you own your own companies. You should also own your own data, okay? Especially your prospective data. Now, obviously, the Connecture tools and the Sunfire tools, when you're doing your actual enrollments, that's a separate deal. But I really think you as an agency owner should have complete control over your own data and not be depending on a third-party organization to provide you with a license to your CRM. You should own your license, because what happens if that third-party organization and that FMO, we're not perfect humans. You could say or do something that significantly deteriorates your relationship with that organization. What happens then to your data? Okay, so that's why you will never see RMA roll out here's a technology tool, here's a CRM tool. There's already 7,000 CRMs that you guys could use, that you can own the license yourself. And so I'm when it comes to CRMs, I'm going to empower you to be your own business owner. Go find a CRM solution that works for you and your business. Now, if you come to me and say, hey, I need my CRM to do 1, 2, 3, 4, these 6 different things, can I provide you with a suggestion as to which CRM does those 6 things? Absolutely. I'd be more than happy to provide you with suggestions if you have clear understanding of what you need out of your CRM tool. But be a business owner, have a CRM, and own your own license. Okay? Very important.
Fair point. I want to go back to the kind of the SAR situation, because I remember the one thing I was going to ask you. One of the challenges I've noticed as somebody who's in the field doing this every AEP is this is typically how the conversation goes with the client. And I wanted to get your input for how we as brokers can help have this issue fixed, or at least address it. So the conversation is, they get on there. I have an hour with somebody on a Teams or on a phone call. This is how the conversation goes. What's changed in my plan? I only have an hour with that person. That instantly tells me they have not read their ANOC, right?
Of course, nobody does.
Nobody reads their ANOC. So my question to you is, and then the second question,
big.
Yeah,
they get
the second question I get is, what's changed in my plan? Am I still in the best plan? Which is the one question we can't answer. So the first question I want you to address is there any way we as brokers can help drive that education with ANOC, because it's such a great tool that nobody reads?
Yeah, absolutely. Well, you see all these AI tools being launched now. So before you have the conversation with the consumer, you know which plan they're on. So why don't you load up both summary of benefits from 2026 and then 2027, load them up into one of those AI tools and say, hey, AI, can you please provide me with a quick summary as to what changes occurred from this summary of benefits to this one? And guess what? It's going to do that for you. Like this. It's crazy. So use AI. Use AI when it comes to these type of solutions, because you can go into that call and say, hey, I just reviewed your 2026 summary of benefits compared to the 2027. Here's your biggest changes. Are you okay with those, or should we shop you a new plan?
Excellent approach.
And you don't even, you steer the conversation. When you get on the phone with the individual, it's like, hey, I'm glad we got on the line. Here's the changes that are coming through with your plan. Are you okay with those? And here's some new plans available potentially in your market that also might be a good fit. So make sure you're the salesperson. You're the business owner. You're talking to someone in the general public that has no clue what the hell health insurance even is. So steer the conversation. Be the person, be the professional in the conversation and make sure to steer it. Well, how do you be the professional in a conversation and steer the conversation? You go into the conversation prepared. Okay. Go into your conversations with your members prepared as you come up to this annual enrollment period, and utilize the AI tools that are free for us to make it super simple. Don't read both summary of benefits and write down what the changes. No, load it up into Chat GPT. It'll tell you, and it'll do the analysis for you in 30 seconds and tell you, you can even tell it, hey, make a Cliff Notes version of this. And it will, and you can just, okay, perfect. I'm a Cliff Notes guy.
Yeah, and check your work, right? It's AI. Check your work.
Yeah, check your work, right? And then, yeah, exactly. You tell the AI, hey, make sure this is right. Yeah, but use that stuff and go into your client conversations prepared and professional, and make sure you're the one actually steering the conversation.
And let's switch now more toward the changes that we are encountering with the final rule, right? Mm-hmm. So there's a lot of chatter right now as far as the call recording retention times change, but there's some nuances to this thing that I don't think a lot of the chatter is encompassing. Talk about those a little bit.
Oh, well, the nuances where we could potentially save the call recordings for less than 6 years if we have these. Just store your calls for 6 years. Let's not play in the nuances. It's like, hey, if you meet these guidelines, you might be able to do this. And remember, too, that is more or less for, those tiny little guidelines. That's more for the large organizations like Connecture and Sunfire to be able to implement within their platforms. That's not something an independent insurance agent is going to be able to implement internally within their system unless they have an AI tool that is in the background saying, hey, this perspective, this person in your CRM meets the qualifications to only store the call for 4 years. You can go ahead and drop that data, and if you're using your Connecture, or I say Connecture because it is Connecture, but it's My Health Plan. If you're using My Health Plan or you're using Sunfire, remember these tools are already storing your calls for you, and they meet CMS guidelines. And so they will be the ones to be able to say, oh, okay, well, we can drop these 400,000 recorded calls because they meet the guidelines for the 4 year as opposed to the 6. So if you are storing call data, just store your call data for 6 years. If you're using Connecture or Sunfire for your call data storage, just know that they know the rules and they'll follow.
Fair point. I mean, that's a great idea. The one thing that I wanted to make sure we keyed on is, because this, I think, is what's going to trip people up. You must maintain the auto recording for the first 3 years of the 6 year retention periods. 4 through 6, you're allowed to keep a complete and accurate transcription instead, but you must still retain the 10 years of the enrollment recording, because that serves as the enrollment form. I thought that was an interesting nuance. So all of the agents and brokers who've gone in and deleted all their 4 year recordings don't do that. No, don't do that. Yeah. And if it's in the client conversations and the stuff like that, where we're talking product detail and we're actually not doing the enrollments and things of that nature, just remember, use your common sense here. When in doubt, just keep it. It's just data.
Right. And if you need help affording an external hard drive because you have too much call data, chances are you probably got a good amount of revenue as well, so you could afford it. Or, call me. I'll see if I can't find you a coupon.
Yeah. Well, I just got a new computer. The computer we're talking, I had to get new because my other one crashed. Right now, my computer has a terabyte of online storage that it automatically syncs all my files to. Of course, I use Windows. I don't use Mac, so better device there.
Oh, you got one of those fancy gaming computers.
Well, yeah. I got to screw around sometimes.
Yeah, yeah, you're up there in the mountains. You need something to do when you're not hiking. Yeah.
Let's go now on to the 48-hour rule.
Yeah.
We've seen some, I don't want to call it flip-flopping, but I don't know what else to call that. Talk about how it's going to be when we can implement that, but then what's behind all the flip-flopping?
Well, so yeah, what's behind the flip flopping is kind of it depends on the administration, right? Because the federal government, depending on what's going on, flops one side to the other, back forth, back forth. It typically depends on what's going on in Washington as far as the 48-hour scope of appointment rule, and if CMS sees independent insurance agents as part of the problem for complaints to Medicare. The 48-hour rule kind of really gives us that, hey, this administration, or this CMS, I should say, this CMS sees us as part of the problem, or this CMS does not see us as part of the problem. Okay. And I've seen the 48-hour scope of appointment rule. Obviously, when I first came into the industry back in 2009, that was the rule, right? 48-hour scopes. And we didn't have technology to collect scopes back then. So we'd have to collect a paper scope and then come back 48 hours, where now we can just text, we can do a recorded scope of, there's so many different ways you can get a scope now that it makes it so much easier. But it comes down to really at the federal level, do they see the independent broker as being part of the complaints to Medicare problem or not? And obviously this CMS does not see the independent broker community as being part of the problem. They've been much more supportive. We see our recommendations through our lobbyist organizations like NABIB. We see our letters being submitted to this CMS actually being read and digested. This, it really just comes down to whether or not this CMS administration, do they appreciate the independent brokers, or do they see them as part of the problem? And this one obviously appreciates the independent brokers, and we see our guidelines and restrictions and things being peeled back, and more guidelines and restrictions being put on the bad actors and the insurance companies and the doctors themselves. So that's where you kind of are going to see the flip flop. It just depends on what CMS is, who is running CMS at that point, and are they taking our advice and appreciating the independent broker community, or do they see us as part of the problem? And it goes back and forth.
Yeah.
Yeah.
That's fair. I mean, those are good comments too. I remember you helped me kind of understand when I was new. I got my license in 2017. You started RMA in 2019. We met right after that, and I was having some profitability issues. It was like, how do I make this better? And you gave me some really good guidance. I wish if you can think back that far, comment on it.
I don't know what I had for breakfast, to be honest.
I know. Well, I'll tee it up. How's this?
So, yeah. You got to refresh my memory a little bit.
In two areas, you helped me. The first one was because I'm primarily a Medicare supplement person that learned Advantage later, whereas I think your typical agent is the opposite of that. But I came to you and I said, having profitabilities with XYZ company, and you said to me, well, why don't you look at ABC company and DEF company, or whatever the other companies were, based on the compensation, but also on the good rates year over year, which I wasn't necessarily getting with XYZ company. And then with MAPD, you said you should have some go-to products with those companies. And I'm seeing with some non-commissionable products, or that lever you were talking about being pulled, that's going to be harder to do, to have go-to companies, but then also go-to H codes. Because I remember I used to call a certain carrier, they had H number blah 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 -250, and in my mind I always called that the 250 plan because it was such a go-to product. But as those levers get pulled for non-commissionable, talked about MedSup profitability as far as comp goes, obviously doing the right thing for the customer, but then also what's the future for us having a go-to, bag of MAPDs?
Well, on the Medicare supplement side, I know we run businesses. So you have to look at is this actually going to be a profitable product for me to actually enroll my consumers into? And is the long-term rate stability going to be there as well? So those are two key things as a business owner you have to truly understand. Now, one of the big, huge Medicare supplement companies that paid the worst commissions in the industry has recently taken some large rate increases, so they're not as competitive. Well, now what do we do in that scenario? Where before we were just writing this insurance carrier because they were obviously the most competitive. They had the fitness membership included it. They preached that they were the best rate stable product in the industry because they were, and now they're going through turmoil. So we no longer have to write them while taking a really, it's pretty significant hit in revenue. If you were just exclusively writing that one carrier that paid reduced commissions on their Medicare supplement product. And so, and not many agents I worked with were doing that because they, again, you got to have a little common sense as a business owner. Like, hey, I'm making $200 less annually if I were to write this Medicare supplement compared to that. Is there enough value to the consumer for me to take that hit? And typically the answer is no. The value isn't there. They've got a great brand name and a fitness membership, but over here you're going to experience the same level of rate stability and the same deal. You're just going to get a significantly higher commission amount. So if you're not paying attention to what your agency's commission rates are on your Medicare supplement plans, you absolutely need to. Okay, you need to take a look at this. You need to have your commission schedules for your Medicare supplement products. They range from 18 to, I think one carrier will pay up to 23% of annualized premium. And so you need to have your commission schedules. If you don't have your commission schedules for your med sup carriers, call our office. We have all those commission schedules for you. We'll email those off. Now on the Medicare Advantage side, can I say next year we're going to have go-to H codes? No, we're going to have another year of instability within the Medicare Advantage marketplace. We are. We just know that because, again, those risk adjustment factor scores, and I don't know if you saw this, but there was a bunch of new rules that were set to go into effect for 2027 that have been peeled back, that more or less gave more risk adjustment opportunity for these insurance carriers, depending on, income level, demographic data, what level of schooling the individual had. There were all these additional risk factors based on equity that were going to go into effect for 2027 that got peeled back. So the insurance carriers that were really prepping for that got hit pretty good because that, again, got peeled back. And now it's just their star ratings are going to be based off of their healthcare outcomes, as opposed to the equity and inclusion of their membership base, and other risk factor scores and all this. I mean, only the federal government can come up with this stuff.
Kind of upended their whole philosophy.
Yeah. So like another big cog was thrown into the Medicare Advantage because the insurance carriers were all prepping to scale their data collection more. The better they were at collecting data, and the better they were at scoring their membership, the higher reimbursement rates they got. And it wasn't even based off of their star ratings. It was based off of the data collection of their book of business. And so I'm glad that went away, honestly. It is going to negatively impact our rural markets until these Medicare Advantage plans continue to figure out how to make this more profitable within this new risk model that we're seeing put into place for 2027. Now, do I expect insurance companies to be able to innovate and make this profitable? Yeah, it's what we do. It's what entrepreneurs do. We innovate and we make things profitable. Is there a year of instability while we figure it out? Yeah, there sure is. So hang on for the ride.
Yeah, right. I know that in preparation for this, both of us watched the interview that Health Tech Nerds did with Chris Klomp.
Yeah, Chris Klomp.
I thought that was
that's what he talked about, was innovation.
Yeah, Health Tech Nerds, thank you for doing that interview. That was brilliant. He mentioned the word insurgent, which is not a word you typically hear. Chris Klomp used that word insurgent. Talk to us about what does that mean to us in the broker community?
Well, insurgent, what he's specifically referencing there is new players, not current existing insurance companies, but new players entering the Medicare Advantage marketplace and heavily incentivizing these new players with these tech platforms. I'll use Devoted as a really good example here. That was a tech company that innovated in their Orinoco system that allows them to be profitable in a highly regulated marketplace. Okay, so that's significant innovation. They invented new technology to make their insurance company competitive in this landscape. And that's what we probably will continue to see, these tech companies building these platforms specifically based off of this new innovation. And also I see some insurance companies taking a more proactive approach and making sure that their members get their preventative care services done as well. And I don't know if you saw my live, but we talked about that a little bit, where these insurance companies now, their star ratings are going to be based off of how healthy or the improved health. So it doesn't matter how healthy the person is when they come into the MA plan, right? They could have 17 chronic conditions. They could be on all these crazy medications, but what the insurance company is going to be scored on is, hey, they entered your Medicare Advantage plan with 17 chronic conditions, taking X amount of medication, and these were unmanaged. 1 year from now, how is that? Are those conditions being managed properly? Has there been hospitalizations? Have you done a good job of actually improving the healthcare of your membership? That's what they're going to get graded on, which I think what that is what they should be graded on, right?
Yeah.
So I'm really excited about that because it's refocusing specifically on healthcare outcomes, and that's what it should be focused on, because that's actually what's going to improve our Medicare population's general health, and they've never been sicker. We as a country have never been sicker. And so I really hope the insurgents in the market, these are going to be large tech companies that have created platforms to make this profitable. And guess what? You think large tech companies are good at selling individual health insurance products to Medicare eligibles? Nope, they're not.
Nope.
And something I see this all the time. It drives me freaking nuts. Yes, the tech companies are good at tech. They're good at building AI. They're good at building advertisements. They're good at building direct enrollment platforms, all these things. But guys, there's no human connection with a computer. And the vast majority of individuals, especially when it comes to their healthcare, want to have a conversation with the person they trust. AI, technology, direct enrollment platforms will never replace us. Okay. I expect us maybe to see a little dip, right? So we account for over 55% of new business into Medicare Advantage companies. We may see a little dip in that, maybe down to 50 with these direct enrollment platforms and different AI tools available. But, I remember when TurboTax first got launched, and all the CPAs were freaking out that they were all going to lose their jobs because now it's super easy for everyone to complete their taxes quickly, online, and cheap. Are CPAs out of business?
No, that's a fair point.
Nor will they be.
Well, and
we be.
You actually hinted at the next thing I was going to ask you. It's like you have a prescience about you that you already know what I'm going to ask. In that interview with the health tech nerds, the gentleman doing the interview started to ask the question about default enrollments, and Chris Klomp kind of jumped on that and did a very, in my opinion, an aggressive answer to it. And I don't think the gentleman asking the question got to ask his question. We've talked about this. Why is this default enrollment thing not that big a deal?
Well, first, there's a big misconception going on that he's talking about default enrollments for all Medicare eligibles. No. Okay, it's not the case. We already do this. We default enroll all of our dual eligible individuals into a standalone prescription drug plan. What they're talking about here is that specific market, okay, the dual eligible population. Okay, they want to default enroll that population into a coordinated care product because guess what? It's so much easier to control costs and healthcare outcomes in a coordinated care plan than it is on fee-for-service original Medicare. So they're talking about potentially for our poor population that is dually eligible for Medicare and Medicaid, instead of default enrolling them into just a standalone prescription drug and leaving them to their own devices within the fee-for-service Medicare model, okay? They're talking about obviously auto-enrolling them into a coordinated care structured type of policy to where we can actually control healthcare outcomes with intervention, which I think is an excellent opportunity. I think we absolutely should do that. Now, does that remove the insurance agent? Well, yeah, in some situations. But do you think that the state government is going to default enroll the Medicaid eligible individuals into the best product into the market? You don't
Or
think
the
we're
one
going to
that
be able
covers
to,
their doctors.
that one that covers their doctors and their drugs, is that going to completely remove our opportunity within the dual special needs market? No. It'll
No.
probably be like a default enrollment into a Denver Health type policy, and we're going to be able to beat the hell out of it with Devoted. So it's like, it's not doom and gloom. I mean, this is not a bad thing, and I really do think that would help significantly, especially original Medicare fee for the original Medicare A and B, because remember, they're primary payers for all healthcare services, and our dual eligibles, our low income folks, they're not getting preventative services done on fee for service original Medicare Medicaid. They're just going to the emergency room when they need healthcare. Okay, that absolutely puts a huge burden on our original Medicare program. So that's what Klump was talking about. He was talking about getting those dual eligible folks into a coordinated care product to where a coordinated care product that is incentivized to improve the actual overall health care of that dual eligible, as opposed to just leaving them to their own devices, because they're dual eligible for a reason.
Well, and you and I have had that conversation for years, where we encounter somebody just through our own marketing efforts in the community, and they're just on a PDP, and it's like that you're so underserved.
I know.
And then you show them the MAPD, and it's like they almost don't believe you because
they
it's too
think
good to be true.
Wait, this is too good to be true. But if they're automatically enrolled into one and they're getting some benefits, and we come in and say, we can just jack these benefits up for you and get you some more flexibility within your provider network. The agents I work with that specialize in the dual program, they know how to replace other dual products. And so that's the auto enrollment into a coordinated care type of product. I don't think is going to hurt us at all. What hurt us was when they took our damn SEP away. That one hurt us. That one hurt us. And we didn't get any new SEPs through this new final rule. We were really, really hoping to see the SEP come through that, hey, if your provider dropped out of network, we'll create we didn't see that one happen, and that was one we really championed. But yeah, no new SEPs, and then losing our dual maintaining SEP last year, that's what hurt our enrollment into the dual market. But again, innovators, right, are creating new opportunities for us. They're coming up with C-SNP, D-SNP plans, right? Well, hey, we got an election period now. If you got diabetes, we got you, so leave it to the innovators. We'll figure it out.
Smart. I like that. The thing I wish, Chris Klump, if you're reading this, or if you're watching this rather, this is my wish list. Cool. Put this on the list if you care what I have to say. But I wish CMS would differentiate between in the field broker and the call centers, because I am not a TPMO.
No.
I don't like being called a TPMO. There's some changes there that I'd like you to talk about, Ryan, but that's my wish list. Chris, if you're listening, please.
We're not TPMOs. I mean, technically, we are third-party marketing organizations. We're not employed by the federal government or an insurance company, but you can't just lump us all into one lump. And actually, I didn't get into too much research on the TPMO changes. I know our TPMO disclaimer changed, and we no longer have to recommend people talk to SHIP, which is nice. Thank goodness, because SHIP are volunteers, and they have less training than the people at Social Security. So...
and we both know people who have worked with SHIP, and people we highly respect. Some are still in the industry, some have retired. There is some value there, but overall, it's like calling 1-800-Medicare and getting the person that just got hired in some cases.
Yeah, most of the time, because again, these are volunteer-based organizations that don't require, it's not like they require you to sit in a classroom and truly learn all of this stuff. And a lot of folks that take these volunteer positions will just be freely to just off the cuff tell you what they think. And what they think is not typically correct. Because they haven't been in the healthcare industry for 20 plus years. They're just volunteering to help the seniors. And it's not like they're trying to hurt the seniors, but they're just freely, there's a lot of humans in this world that will just freely say what's on their mind. and what's on their mind is not right.
Yeah.
And that happens very frequently, especially within a volunteer population. And SHIP is a volunteer population. So there's obviously excellent SHIP coordinators. I'll use one of our agencies out in Durango, Colorado as an example. They used the local SHIP office to do their Part D enrollments for years, and they were excellent at that. So, but I am glad that got peeled back. So the biggest change to I guess for TPMOs that I have digested so far is that they're starting to scale back what we have to provide in our disclaimer. And then obviously we still need to work on redefining the language and breaking the segments of our industry up. Here, these are field marketing organizations, these are call centers, and these are EDC, independent insurance agents. You can't just lump us all into the same bucket. And I think they're starting to realize that, and we're actually starting to make some traction.
Well, and I've had the experience that one of the changes that I liked, so thank you for this, CMS, was you don't have to rush within the first 60 seconds to do the TPMO disclaimer. These are clients that we have known for years. You get on a Teams like this, or you go visit them in a local market, and you're supposed to say, "Hey, how's it going? Oh, by the way, I do not represent every plan in there."
Yeah, what was it? We had to read that damn disclaimer within like the first 30 seconds of answering
60
our phone.
seconds.
Within the first.
Yeah, so now that's been rolled back. Thank you.
Yes, thank goodness that got rolled back. Okay, we don't have to obviously do the TPMO verbal disclaimer with someone is within the first 60 seconds of us having a conversation about product information.
Because we are not a call center.
We're not a call center, right? Exactly. And so now that TPMO disclaimer, if you're doing an over-the-phone sale, just needs to be read before you start your enrollment process. It needs to be as part of the enrollment over the phone. So you read that disclaimer once you get into the actual enrollment activities of the application, as opposed to within the first 60 seconds of your call recording. So that was a great rollback. So yeah, I completely forgot about that one. Thanks for pointing that out. I saw that. And then so the TPMO disclaimer has gotten shorter, and we only have to read it when we actually get into the enrollment process, as opposed to, our current client calling us, "Hey, can I just run through what the cost of, this would be on my Medicare Advantage plan? Can you help me understand my summary of benefits?" Yes, hold on one second here. So no, thank goodness. Yeah. So again, this administration, this CMS, we'll say, right? This CMS is taking our suggestions, and you can clearly see they don't see the independent broker community as being part of the problem. So we're seeing our regulations being pulled back. And again, that's ebbs and flows. The next CMS could be completely different and want the 48-hour scope rule back. So that's just it's the game we play in. We work with a federally regulated health insurance product. Of course, there's going to be regulation changes.
Sure. Mm-hmm. Well, and just if I can, pat myself on the back a little bit as an old dude, I created some videos because I had to support my clients because of the SARS situation we went through. I had to do most of mine like this through Teams. Mm-hmm. And what I did was I created some videos that were my TPMO disclaimer, but it was a video. So it came up on the screen. It was a voice reading. Of course, I used an AI voice because I don't like the sound of my own voice. So I used a very nice female voice. And I got my TPMO disclaimer, and I didn't have to keep saying it 50 million times during my busy season. I actually created a video for the verbal SOA just so I could have that. If I got on there and I looked at my notes and my assistant had put them on my calendar and I didn't have an SOA, I said, "Look, we have a 48-hour rule. This is how it works. I'm going to play this video. We're going to archive this, and then 48 hours from now, let's get back on Teams." But I created a video for the verbal SOA because when you look at it, the verbal SOA is not that big a deal. It's actually not that dissimilar from the TPMO disclaimer.
Right.
So there's some creative things I think agents could do there that.
Yeah. So you used an AI tool more or less to put a video together that you can just hit play for the TPMO and the scope of appointment.
Yeah.
I think
those are easy to create these days because. And then you just have the file there. And only one time it was an older gentleman who couldn't hear it. So then I had to read the TPMO disclaimer and yell into the
Yeah, that lady's voice wasn't the exact decimal that his hearing aid could pick up. I understand. Yeah.
Yes, and
Brittany
that's
seems to
so
Brittany seems
lessons
to have that
learned.
problem quite a bit for some reason. It's like her
Yeah,
her voice
lessons learned.
frequency just doesn't
Don't
resonate.
use a high decibel female voice for your TPMO disclaimer. It's a bad plan.
It's a bad plan. The old guys can't hear it. The old guys can't hear it.
Yeah, it's the same frequency as their wife's voice. They're not going to hear it. So, FYI.
Yeah, they've been.
Well, Ryan, we're a couple minutes over. I want to respect your time and our listeners' time. So, thank you for this. Do you have any closing comments or thoughts that you want to sum it up with?
Yeah. So CMS final rule. Okay. So the biggest takeaways to the broker community. The 48-hour rule got rolled back. We're not going to have to worry about that for our 2027 enrollments. The TPMO disclaimers changed, and obviously we don't have to read it until we start the sales process. Big change to the independent broker community. The star ratings have been refocused and specifically focused on healthcare outcomes. I think long-term, that's going to be a good thing for long-term stability. Next year should be the last year of instability because, again, it's the last year these insurance companies are taking the big hit on the rolling back of the risk adjustment scores, okay? And so we're going to have one more tough annual enrollment period where we're going to see ancillary benefits decline. So if you're not currently up to speed on standalone dental, hospital indemnity, because we very well may see max out-of-pockets grow as well. And we can, we can insure those, okay? We have ancillary products. So make sure you're attending our courses. I mean, we have an excellent conference coming up here soon. So make sure you're engaged and you're attending our additional trainings, and we're here to help.
Well, in 2027 is going to be the year of the ancillary. If you focus primarily on the MAPD market, the Kaiser Family Foundation does a lot of research. 54% of Americans are on Medicare Advantage nationwide. And that trend, the Congressional Budget Office, they've chronicled that by 2030, that's supposed to be like 64%. It's not going anywhere.
No.
So we've got to make this the year of the ancillary. If you don't already offer the products Ryan's spoken about, talk to Ryan's team about hospital indemnity. Talk about additional dental solutions that Ryan's team have. There's some different solutions, that price points, right, for the different markets that we deal with.
Well, and I finally figured out how to sell against Delta Dental, so I might actually be able to be profitable in the dental industry because
sell some dental products.
Sell some dental products. Our discounts over at NCD and Emeritus are significantly better than Delta. Blah, blah.
Well, Ryan, you're a good friend and a good friend of the industry, so thank you for taking the time to do this. We really appreciate you.
Well, yeah, thanks for providing me with the encouragement to start doing this. And I hope we have some good conversations in the future as well, because I know we're going to hope to try and do this on a monthly basis, more or less, to what are the big topics in the industry that month and what do we need to understand about them so our broker channel and our EDC community can be better prepared for it.
And obviously, we're going to post this in Ryan's Facebook group for his team. Feel free to comment on any of the posts there, what you'd like us to see focus on before, or we're going to put this on YouTube as well. Put your comments in the chat, or excuse me, put your observations in the comment section as to what you want us to see focus on, because we have a little bit of data for what people want us to talk about, but what I've noticed is very niche. It's very, like, I want to know about this one thing. Like, one of the examples that we saw a few people comment on was, it was something to do with the
QMB versus QMB plus,
Quimby, Swimby, all that nonsense that the states on a county basis manage. How could we possibly do a video about that? But maybe we'll try. I don't know.
Yeah. How do we know? What are the scenarios? It's up to the county, and there's a lot of counties in the country.
Yeah, it's a lot.
A lot. Yeah, so it's really hard to delve deep into that. It's just, hey, here's our income guidelines. This is what we know. It's up to the county from here.
Yeah. Okay, well, Ryan, again, thank you. Appreciate you very much.
Yeah, appreciate you, buddy. We'll talk soon.
All right, speak soon.